Good day, everyone, and welcome to this session on pneumonias and lung abscess. You have here my identifier. So thank you very much for joining me today for this very important topic. Why is it important? Because lung infection remains to be number one, consistently in the top three or top five causes of morbidity and mortality in the population in the Philippine setting. What is important to notice is part of this is preventable, and some of which may entirely be avoided by proper intervention like vaccination. So let us start with our goals. Quite a long list, but we'll try to cover this as briefly as possible. I would like you to read Harrison's because most of the examination questions are going to be picked up there. My task today is to guide you into the clinical application of the same topics, especially in relation to the international and local guidelines pertaining to community-acquired pneumonia, also including hospital-acquired pneumonia and ventilator-associated pneumonia, and one of the common complications of both of these processes, which is lung abscess. So briefly, the respiratory system is designed for oxygenation and carbon dioxide elimination. Carbon dioxide, a byproduct of cellular metabolism. And this is important to be able to do that appropriately. But to be able to, again, to do that is to distribute or deliver a huge amount of volume of air, something like 2 swimming pools of air in a 24-hour period for us to be able to do this. And our anatomy are designed and supported to protect our respiratory system, both the airways and the lung parenchyma, from invasion from microorganisms that causes infection. And any breakdown of those protective mechanisms, like the habit of smoking, which has a direct impact on the airways, with its ability to clear organisms that lands eventually into the alveolar structure and the airways, impairs these defenses and therefore sets us up for increasing predisposition to respiratory infection. By definition, pneumonia is the infection of the lung parenchyma. So whether this is acute, like viral, or acute ordinary bacterial infection, or the long duration lung infection or the lung parenchymal infection like tuberculosis, may still be considered as a pneumonia. Only the clinical presentation are going to be different, and pulmonary tuberculosis is going to be a topic of another session with you. So the classification now evolves around where we got the infection, whether this is coming from the community, and the associated or predicted etiologic agents. Recently, etiologic agents have evolved, especially in North America, especially in the United States, where organisms that are previously not identified as a common pathogen had become a pathogenic organism. And then you talk about hospital-acquired or previously termed as nosocomial pneumonia. And this is subdivided further into HAP, or hospital-acquired pneumonia, ventilated HAP, the individuals who develop the pneumonia in the hospital and eventually requiring intubation and mechanical ventilator, and then an individual who came into the hospital already ventilated by accident or stroke or other catastrophic events like an acute myocardial infarction, gets intubated and lands into the ICU, where they now develop, while on ventilator-assisted devices, develop lower respiratory tract infection. And as we said, the normal anatomy and normal physiology allows our body to protect from invasion of these organisms. And you see here, by review your anatomy, the structures that are very important. And as I said, any breach of all of this, or any or all of this, especially in individuals who have multiple organ problems, will definitely increase the probability of getting a respiratory or lower respiratory tract infection. And this is the cartoon that the normal flora that you have in your airways, upper airway, may become colonized. Individuals who get hospitalized within 24 hours, whether the hospitalization is because of an infection or not, they become colonized by the organisms in the hospital setting. So you can imagine that these individuals are already sick, being colonized, and can now be a setup for hospital-acquired infection. But we will focus first on the community-acquired pneumonia in immunocompetent individuals, because immunocompromised individual presents differently and their management are different from what we're going to discuss now. So once they're colonized, then the usual route would be inhalation or aspiration, and commonly aspiration. Even normal individual during sleep, we can aspirate, microaspiration that cost can now settle into the lower respiratory tree if our immune system and if the barriers are impaired, can settle into the down into the alveolar structures and eventually develop lower respiratory tract infection. And this is in cartoon again, the pathophysiology. The host defenses fail, not only one, but part of the defense, and then the pathogens infiltrate and proliferate in the alveolar structure. And then the immune system responds, because this is a response in protection of the from the respiratory infection. And you will have here all the inflammatory cells coming in to control this infection and the inflammatory process that is triggered off. And some of these inflammatory processes, not necessarily the proliferation of the bacteria itself, leads into some of the complications like leaky alveolar walls and pulmonary capillaries. And we have talked about this in ARDS, that individuals with severe pneumonia can eventually develop non-cardiogenic pulmonary edema, and the blood vessels and the alveolar structure becomes leaky and floods the respiratory system, especially the gas exchanging units. And they eventually lead to gas impairment and eventually respiratory failure requiring intubation and mechanical ventilation. So these are some of the defense mechanism, and I'd like you to go through all of these things in your reading in Harrison's. But the organisms gain access into the respiratory tree essentially commonly through aspiration. Healthy individuals even as commonly harbor pulmonary pathogen in nasopharynx, especially if you smoke. And microaspiration occurs even when you're awake. You suddenly just aspirated and you can cough. Then the organisms that are associated with this kind of setup are the usual organisms: strep, pneumonia, Haemophilus influenzae, Moraxella, anaerobes if it is gross aspiration. Gross aspiration is when you have massive aspiration into the respiratory tree. Somebody vomited because they are asleep or alcoholics or had a stroke. Then those are called macro aspiration. And then the organisms may be gram-negative organisms, previously called Enterobacteriaceae, now called Enterobacterales. Inhalation of infectious particles are not a common route of developing low respiratory tract infection, but tuberculosis is one of these. COVID-19, as we eventually realized, was airborne in nature, and therefore this is one of the pathway with which organisms can reach the lower respiratory tree. And then there's some clinical instances where hematogenous is spread. Patients with bacterial endocarditis, for example, or the catheter that has been placed for IV medication or fluid becomes colonized and invaded by Staphylococcus aureus, and subsequently you will have hematogenous spread of infection. Some may be related to extra pulmonary bacteremias, soft tissue infection, for example, just a complicated or infected pimple, maybe a focus for hematogenous dissemination, and you will see multiple areas of the lungs being involved with this kind of presentation. So when you have pneumonia of multifoci in the lungs, then reach for a possibility or search for a possibility of a focus that disseminates through the blood these organisms from infected sites. Direct inoculation is quite easy to understand. If you have chest wound, maybe an open wound, a penetrating wound to the chest, from blunt trauma as well, can create penetration into the thorax, and subsequently this gains access into the lung parenchyma. infection elsewhere, like mediastinum or subphrenic space, like if you have liver abscess from either amoebic or bacterial liver abscess, can gain access through the diaphragm into going into the intrathoracic uh, location. So the inflammatory response of the host is what is responsible for recognizing the syndrome of pneumonia, fever, chills, and we will see later on exactly how this happens. When organism gains access into the lower respiratory tree, then our immune response tries to control it. And this interaction between the organism in our response, especially the alveolar macrophages that initiates this response. And it triggers the response with TNF and IL-1, which immediately can be manifested as fever. And subsequently, some of the chemokines, IL-8, GCSF, recruits cellular component into the lung, and peripheral neutrophilia happens, and subsequently white blood cells comes pouring out into the respiratory tree, and you will have purulent phlegm here, being a manifestation, clinical manifestation of this inflammatory cascade. And then again, it becomes generalized. From a local problem, you can have sepsis and you can have dissemination in the blood, but progression of this inflammatory process and infection results into systemic inflammatory response. You have mediators that now inflames the alveoli, even the pleura, and then you have capillary leak. And the purulent sputum and some of these problems interacting in the lung parenchyma gives you the cough. The respiratory system tries to clear up the infection, and therefore the only reflex that the respiratory system can do, whether it's a secretion, whether it's bronchospasm, or whether it's stiffening of the lungs, the respiratory tree coughs, and therefore that is quite a stereotypical response of the respiratory system to any of these processes. Then from here, you will have all of the pathophysiologic problems. Ventilation perfusion mismatching results into hypoxemia, and hyperventilation results into respiratory alkalosis. This now presents as difficulty of breathing. Your lungs become stiff and therefore less compliant, and your patient also feels this inability to expand the lungs properly, and subsequently recognize this as difficulty of breathing, and manifest as increasing work of breathing, tachypnea, hyperventilation, your saturation goes down. And if this is not stopped or controlled, then this can lead to patients eventually dying from this lower respiratory tract infection. So we have already reviewed some of this and how it is manifesting. You have localized capillary leak, and therefore you will see this as opacification on your X-ray, and consolidation, which typically presents as a lobar infection in bacterial, the usual bacterial type of pneumonia. And then you have your physical examination findings. You have crackles, accentuated breath sounds, dullness on percussion, and the physiologic or pathophysiologic consequence of hypoxemia. Extravasation of red blood cells and through the breakage of the alveolo-capillary membrane may result into hemoptysis. And then you have this systemic inflammatory response, and you recognize this as increasing work of breathing, increasing respiratory rate and volume. Classification of pneumonia had been tried, and this is what we're going to employ. At some point, there was a classification termed HCAP. They said that individuals who have regular interaction with healthcare facilities, like individuals who are dialyzing in and out of the hospital for chemotherapy, or repeated interventions or procedures going into the hospital, was considered to be highly harboring drug-resistant organisms. But this was eventually discarded, because it eventually was found out that if you label individuals like this as HCAP, it results in overtreatment and overuse of potent antimicrobials. And therefore, currently, this is no longer utilized, but rather assessing individual risk factors for an individual for multi-drug resistant organisms. So you have community-acquired pneumonia, you have hospital-acquired pneumonia, you have ventilated hospital-acquired pneumonia, and individuals who develop the infection while undergoing invasive mechanical ventilation. And the emphasis here is invasive mechanical ventilation because it's not the mechanical ventilator that's causing it. It's actually the endotracheal tube interface between the patient and the doctor that conducts or increases or sets them up for this respiratory infection. This is quite an important concept because from community-acquired pneumonia, when your usual typical organisms going into interaction with the healthcare facilities, developing hospital-acquired pneumonia and ventilator-associated pneumonia, both are in the hospital, leads to increasing potentials for being infected with multi-drug resistant organisms and subsequently drives increasing morbidity and mortality. So again, the emphasis now is identifying risk factor for MDROs rather than focusing on these individuals who have interaction with healthcare facilities. In 2016, this prediction score came out, but was not in place and subsequently hasn't been used regularly in the clinics to identify individuals who might be at risk for developing drug-resistant lower respiratory tract infection. So focusing on CAP, these are some of the important adult CAP guidelines from the states, 1993, and eventually combining groups of concerned organization, American Thoracic Society, CDC, Infectious Disease Society of America, and look at the guidelines that have emanated because of the new information and the development of new understanding about etiologic agents, new approaches to the diagnosis, and eventually also strategies for treatment. Maybe not new antibiotics, but rather strategies on using current antibiotics and maybe utilizing some of the very few recent antibiotics that have been developed. In the Philippines, we have the latest guideline in 2020, now adopted by PhilHealth in 2024, which we are going to incorporate in our discussion. Organisms, because we eventually are concerned about what kind of organism causes these lower respiratory tract infections. For outpatient, these are the core pathogens or the common pathogens or common agents. Streptococcus pneumonia is top. And as you will see, even with hospitalized patients in the ICU and the ICU, non-ICU and the ICU situation, Streptococcus pneumonia remains to be the top of the list. And therefore, in the preventive aspect, vaccination against streptococcal pneumonia or pneumococcal vaccine is what is recommended to cut down on the potential for this infection occurring in the community or even individuals who are brought into the hospitals because of severe community-acquired pneumonia. And then you have the atypical organisms, Mycoplasma, Haemophilus, and Chlamydia pneumoniae. And more recently, we have respiratory viruses. And you see COVID-19 is a respiratory virus that killed millions of people worldwide. So again, when you are in the hospital setting, you have the same core pathogen, respiratory viruses, but once you get into the critical care units, then you will have more preponderance of gram-negative organisms, H. influenzae, and some of these hospitalized patients will develop respiratory infection secondary to multi-drug resistant organisms. These are some of the causes. Typical bacterial pathogen that we have mentioned already. These are the atypical bacterial pathogen. They're not readily identifiable by gram stain or even culture culture measures, and therefore they are called atypical. And they do not present as lobar consolidation as well. They usually present as interstitial infection. However, these are not hard and fast rules, and no specific radiographic pattern can tell you whether that is caused by an atypical or typical organism. However, Asian studies, and these have been supported, we are part of this study in this group, that isolates from the community setting. You will see Streptococcus pneumonia, almost 30% of those isolates belongs to Streptococcus pneumonia. And in some series, this is as high as 40 to 50% of bacterial etiologic agent coming from the community is from Streptococcus pneumoniae. And therefore, the emphasis is, again, to cover this organism uh, whenever you are entertaining a possibility of a serious lower respiratory tract infection. What else do we have as far as risk factor? Um, Comorbidities, as you are, what number one driver for increasing low respiratory tract infection is age. So you can see the difference here between 50 to 64 and those 65 and above. And as you will see, the incidence increases and even doubles in some of these clinical conditions. But down below here are comorbidities. Those with no comorbidities would have a lower incidence of development of the problem, but you have here some of the clinical condition, top of which would be chronic lung disease, COPD, emphysema chronic bronchitis in some part of the world, this is cystic fibrosis, but you also have asthma. And look at smokers. Being a smoker alone is a risk factor, especially when you're elderly. And so there is no healthy smoker. Whether you're young or you're old and you are smoking, then your risk for all-cause pneumonia, this is all-cause pneumonia from the United States, is going to increase your possibility of developing lower respiratory tract infection. We're familiar with diabetes mellitus, but if you look at diabetes mellitus, it has even a lesser incidence compared to somebody who's just smoking. So remember that if you're smoking, whether that's a standard cigarette or vape, you are at risk even at your age. Now that I'm talking to you, some of you are smoking vape, and you think that vape is safer than cigarette. Think again, because this is even worse because you do not know what it has inside and what can it do to your lower respiratory system. So this is a table that tells us some of the risk factor like alcoholism and what specific etiologic agents. You have alcoholism here, and then you have streptococcus pneumonia, oral anaerobes, because so the alcoholism is also related with impaired consciousness when they pass out. Then you have COPD and smoking, and again, the etiologic agent. If you have severe COPD, that is interpreted as a structural lung problem, like bronchiectasis, then it sets you up for example, Pseudomonas aeruginosa, and again, Staphylococcus aureus. If the patient is elderly, has dementia, stroke, decreased level of consciousness, then aspiration is quite an important consideration. And you have oral anaerobes because they're the ones who are at risk for macro aspiration, large volume aspiration into the lungs. So you have anaerobic infection and gram-negative enteric bacteria. Lung abscess, when they present, think of CA. CA is community-acquired MRSA. I was talking to about this earlier on, that methicillin-resistant Staphylococcus aureus coming from the community is a growing problem now. Then we should recognize how it clinically presents. Then oral anaerobes, we don't have this kind of problems, especially because these are US concern, but travel to Southeast Asian countries like Thailand, Bangkok, Vietnam, and the Philippines is a risk for Burkholderia pseudomallei, causing myelioidosis. And again, avian influenza viruses. And then stay in the hospital with infected air conditioning units or a cruise is a risk factor for Legionella. And look at this, some of these important risk factor. Exposure to infected humans, travel to areas, you remember during the pandemic, where part of the criterion is travel to mainland China. But when it became global, it doesn't matter anymore whether you came from, because you are at risk for developing SARS-CoV-2 and COVID-19 disease. And again, this is just a reflection or reiteration of some of the problems. Community-acquired pneumonia is very common among alcoholics, asthmatic, COPD, immunosuppression, those who are in institution, including prisons, and getting old. And then you have pneumococcus, staphylococcus, and some of these etiologic agents. The presentation may be commonly acute. Subacute courses like more than 2 weeks raise the possibility of pulmonary tuberculosis. But the acuteness is hours to days to few weeks, especially if it's a viral infection. Out of the blue, they become febrile and chill, coughing with lower respiratory tract symptoms. A combination of cough, purulent sputum, dyspnea, pleuritic chest pain. This is the typical presentation of community-acquired pneumonia. And then you have generalized symptoms, frequently fever, but in elderly individuals, this may not be very prominent. So don't look for fever if you have an elderly individual. Sometimes they don't even cough. Their respiratory symptoms are very minimal, but they commonly will present with a new confusion or sometimes falls. They lose their balance and they fall. When you investigate, they are already suffering from pneumonia, and this is shown by your radiographic evidence. PE examination, you are familiar with the consolidated changes, increasing breath sounds, bronchophony, whispered pictoriloquy. You have pleuritis with or without effusion, and then you have crackles, fine crackles, and some of the individuals may have airways involvement and they will have wheezing. So by clinical presentation alone, the accuracy is very dismal, 60 to 76%. And some clinical prediction rules, as we will discuss later on, combining physical examination and the history and even laboratory studies may indicate to us that the patient clearly is suffering from pneumonia. And some of the studies have indicated that if your temperature is above 37.8 and you hear crackles and the saturation is below 95%, and you are familiar that you're using pulse oximetry very commonly now, if a previous saturation is known when they were well, a drop by 3% from that baseline indicates a significant drop in oxygen saturation, and you need to investigate, and that increases the risk of the development or the chances that the patient has pneumonia. And a pulse rate in response to the systemic inflammatory manifestation of the patient is quite an important indicator as well. So use your pulse oximeter. Young individuals should have a normal pulse oximeter of about 98 and above. So if the pulse oximetry is 95 and below, then investigate. If you know the baseline and there's a drop of 3% from that baseline, then again, that increases the risk of low respiratory tract infection. So, because of the inaccuracy of history and physical examination, especially early in the clinical process when you don't have the consolidative changes that you're expecting, you might miss it. And that's the reason the recommendation is get an adequate X-ray. And these are the characteristics of the X-ray that you will need. You need it for the diagnosis, and PhilHealth will require that you did an X-ray before they can reimburse you for claims. It confirms the presence of and location of infiltration if it's one side, if it's multifoci, if it involves both lungs. This connotes that the clinical condition is more severe, and that's the reason for asking for this. You also would want to see any information that you can gather from your chest X-ray, like cavitation or effusion, because effusions, especially if they're significant, may need to be tapped or aspirated for diagnostic testing and relief of symptoms. Rules in and out other diagnoses, especially if there's a concomitant possibility of tuberculosis. If your infiltrates are apical in location and you have cavitary lesions, then think pulmonary tuberculosis, but cavitation elsewhere in an acutely infected individual, think of necrotizing pneumonia secondary to MRSA, number 1, or Pseudomonas aeruginosa. However, this may be normal in some situations if you take the X-ray too early, and this is what is called as radiographic lag. It's not common. It occurs in 2% of instances, but it can happen that you took the X-ray too early, so that even when your PE is highly suggestive of pneumonia and your X-ray is normal, then you might have to repeat the study 24 or 48 hours to be able to demonstrate the consolidation that you were looking for initially. In the ATS 2025 guideline, they now recognize the use of POCUS, point-of-care ultrasound evaluation of the chest. And they say that in centers where this had been used extensively and had been trained, then individuals suspected of cough may undergo POCUS and use this as an alternative way of diagnosing pneumonia in place of the standard radiograph. In healthy individuals like low-risk community-acquired pneumonia, it may not be necessary, but they cannot claim field health benefits because you don't have that radiographic evidence of pneumonia. This is just an X-ray. These are normal X-ray views, by the way. Those lines are just to represent to you the distributions of upper lobe, right middle lobe, and lower lobes. And this is on the lateral view, upper lobe, the lower lobe, and the right middle lobe, just to demonstrate to you the usual appearance of an individual who doesn't have a pneumonia. This, on the other hand, is an abnormal radiograph of individual who has the typical lucencies in the lower portion of the lungs, both in the PA view and the lateral projection. And you see lucencies at the bottom, prominent bronchovascular markings, and this is an individual with bronchiectasis. These are structural damage to the lungs that is a risk for harboring organisms like Pseudomonas aeruginosa or even Staphylococcus aureus. So one of those risk factors for Pseudomonas aeruginosa is an individual with bronchiectasis and eventually develop community-acquired pneumonia. And as I said, there are no characteristic radiographic pattern that can predict the likely etiology. You need microbiological isolation for this to happen. An initial normal chest X-ray, as I said, may be the radiographic lag, and then a routine follow-up when a patient is improving is not required when they are hospitalized. But if they are elderly and smoker, you need, it's recommended that you repeat the X-ray 4 to 6 weeks after to establish a new baseline. And to be sure that the pneumonia is not from an obstructive tumor lesion from these high-risk individuals who have smoking history and elderly and male. And so these are the lobar consolidation that you will see typical. Immediately you can see the lungs are white in those regions where your physical examinations are abnormal. Then this confirms your diagnosis of lower respiratory tract infection. And you see here again, but you see the density here. You cannot entirely rule out an underlying problem because a mass lesion may be hiding in this dense problem. And then you have pneumatocysts. These are breakdown of tissues that are commonly associated with MRSA, lung necrosis or tissue breakdown. So when you see pneumatocysts or cavitary lesions in very sick individuals, think one, tuberculosis if they're in the upper segment, but elsewhere in the lungs, think of a necrotizing organism like Pseudomonas and Staphylococcus aureus. This is COVID-19 pneumonia, and as you will see, and standard X-ray shows immediately a white lung. There's a peripheral distribution, but when you do the CT scan, you can see the extensive involvement of this viral infection and the inflammatory process that starts, that it initiated in the lungs, and subsequently most of them will die because of severe respiratory failure and some of the complications. Then not only pulmonary, but hemorrhagic and thrombotic strokes, multiple organ system failures. So this was quite a heavy burden during those years of 2019 until 2020, 2022, 23. And we're lucky now that this is just a die down, and hopefully there's no new pandemic that is brewing in. Some of the routine examinations that are done are sputum examination, but for it to be recommended to be valid and representing low respiratory secretion, it should have less than 10 epithelial cells and more than 25 polymorphonuclear leukocytes per low power field. Because if the epithelial cells are higher, then it speaks of an upper respiratory secretions, and therefore are not reliable sample for culturing those samples to tell you what the cause, the organism that is causing it. And this is one example of a gram stain. You can look at all of these rods. You can have a bunch of grapes, and you're familiar with microbiological examination of diplococci, how streptococcus looks like, and how staphylococcus look like, and gram-negative rods. And then you can now make a decision, initial decision, whether you have a purely gram-positive organism infection or a mixed type or a purely gram-negative infection, depending on the clinical scenario that you have. Other tests, blood culture for some hospitalized patient. Some guidelines would recommend if you have an admitted patient, get routinely 2 blood cultures and sputum examination. If there's pleural fluid, then tap for because this can give you a direct and sterile specimen to show you the etiologic agent. Some would recommend urinary antigen test for Legionella and pneumococcus. The availability of the study is quite limited. PCR for Legionella research, and for tuberculosis, you are familiar with Gene Expert, that if you suspect tuberculosis, you can ask for PCR-based Gene Expert examination, and that you can immediately have results. Serological testing for atypical organisms are quite dismal because you need a pair test, and 4 weeks apart doesn't give you the information when you need it. So in low-risk microbiological studies are optional because, again, the actionable result is far too late in coming, and you might have to decide on treatment rather than waiting for your organism. In moderate and high-risk CAP, blood culture gram stain with antibiotic sensitivity testing for respiratory specimen should be done in laboratories with quality assurance, not some laboratories where you cannot be assured of the reports and subsequently the sensitivity testing. So this is an updated recommendation. This is from the 2020 PSMID community-acquired pneumonia, gram stain and culture for respiratory specimen for moderate to high-risk CAP and individuals with risk factors for multi-drug resistant organism infection. Again, blood cultures for moderate to high risk, Legionella antigen for high risk CAP, and pneumococcal urine antigen. Influenza testing, we already have this now, although quite expensive. You can have a limited respiratory panel with COVID-19 and influenza A and B and RSV, because these are some of the important organisms that you should make a decision on. For severe CAP, high influenza activity during epidemics, high-risk individuals who are asthmatic, pregnant, or elderly, and those with one or multiple comorbid conditions. Multiplex PCR assay, we will discuss this towards the end of the talk. This is not routinely recommended because a pneumonia panel, for example, costs about 13,000 pesos. And it can give you immediate or even more than that. Some would cost like 25,000 pesos just for the testing. But immediately it can give you the organism and the potential resistant pattern that you can have. And some of these have been used in seriously ill patients. But again, the cost and the availability is quite prohibitive. Procalcitonin as a biomarker is not recommended for the diagnosis, but rather the recommendation is to use it for discontinuation of antibiotic treatment. One important question is if I diagnose pneumonia, where do I treat the patient? So whether you can treat them as outpatient in the regular room or have to put them in ICU immediately because of the risk of unfavorable outcome and even death. So some of these risk stratification, severity of illness scores like curve 65, predominantly coming from Europe, with all of these components, and PSI, pneumonia severity scoring from the United States, may be used to identify patients with CAP who may be candidates for outpatient management. Because here the aim is to identify individuals who are not sick enough that can be treated as an outpatient to cut the cost of unnecessary hospitalization, exposure of these individuals to hospital environment, and the tremendous cost of being hospitalized and being treated for something that you can treat as an outpatient. So this is curve 65, some of the important risk factors. That's the reason it's called curve 65, confusion, rhea, respiratory rate, blood pressure, and age. In any 0 or 1, the expected mortality is low and they are likely suitable for treatment outside. 3 or more of these risk factors, high mortality of almost exceeding 20%, and then manage in hospital as a severe pneumonia. In between, manage them in the hospital for a short observation, but in the regular ward. Because this now can assure you that can target these individuals and manage them as an outpatient. And these individuals now results into a more extensive or prolonged observation in one group, and sometimes uh, intensive care unit admission on these individuals. So this is a severity score, and this is the application of curve 65. 0, 1, 2, 3, and 4. You have outpatient, you have ward, and then you have 3, 4, 5 gets to the ICU. This is PSI, but look at the numbers of variables that you need to look at. And so it's quite cumbersome, it's quite expensive, and that's the reason it's not routinely used clinically. So we're using curve 65 or even just CRB 65. Because urea may be dropped off, and they said it will not significantly affect the outcome of your curve 65. However, if you have severe community-acquired pneumonia, and this came from ATS way in 2019, if you have 3 of these minor criteria, or just one of the major criteria, invasive mechanical ventilation is required, or septic shock with need for vasopressor, that patient goes immediately to the ICU because they are at risk for poor outcomes, being intubated, even with just 3 of these minor criteria. You should admit them into the ICU for better management and better monitoring of outcomes. So objective criteria or score should always be supplemented by your clinical decision process, including the ability to safely and reliably take oral medication and availability of outpatient support resources. This is from 2007 ADS. Again, who needs hospitalization? In our clinical guideline, Philippine clinical guideline, there's a combination of this scoring and the clinical features, and therefore we incorporated both what had been proposed internationally, and we adapted it from earlier on in 2000 and early 2000 and subsequently 2016 and then 2024. And this is the clinical approach that we have. So you group the patients to low-risk individual with these features, moderate-risk individuals with these features, and high-risk individuals who has all of these features, plus severe sepsis and septic shock or need for mechanical ventilator. This is low risk, this is moderate risk, this is high risk. But for simplicity's sake, just remember individuals with severe sepsis and septic shock and need for mechanical ventilator, immediately they are high risk because our guidelines do not consider 3 minor criteria, but rather just this one. But if you have all of these things, then immediately that individual goes into the ICU. And this is the algorithm to remember. All of this, if they don't have this, then they're low risk cap and they are managed as an outpatient. If they have any of this, they immediately go to the moderate risk. But if you have these 2 factors, then they immediately get high risk categorization and they are admitted in the ICU. Now, as early as 2007, it was recognized by the ATS IDSA that until more accurate and rapid diagnostic methods are available, the initial treatment for most patients will remain empirical. Empirical means judging on your history and physical examination findings. You start the antibiotics without the benefit of microorganism or microbiological result yet. But as I said, the PCR panels allow us to identify using multiplex amplification studies to be able to identify organism and even patterns of resistance. So again, the core organisms is identified in the US data, and subsequently, how do we recognize individuals may be harboring multi-drug resistant organism? This is from our local guideline. This is from IDS ATS, and you will see here that we have adapted most of the risk factors for drug-resistant organisms from the IDS and ATS and incorporated that in the PSMID recommendation. ESBL risk, Pseudomonas aeruginosa, and as you will see here, high on the list would be prior colonization or infection with ESBL producing organism within 1 year. Risk for Pseudomonas. ESBL is extended spectrum beta-lactamase producing organism. Pseudomonas aeruginosa is prior colonization again within 1 year. Severe bronchopulmonary disease like severe COPD and bronchiectasis and recent prior tracheostomy, because this is an invasive procedure into your airway and predisposes these individuals, because commonly these tracheostomy are placed in the hospital setting where they can be colonized with Pseudomonas. So if they had a recent tracheostomy and they develop community-acquired pneumonia, think of this as a risk factor for Pseudomonas. Risk for MRSA, methicillin-resistant Staphylococcus aureus, is again isolation of the organism in the prior year, intravenous antibiotic therapy within 3 months. And this is where it came from commonly. And so you can see the adaptation of our local guidelines from the international guideline. Here, Pseudomonas and MRSA, and this is from the US data. Presence of any strong risk factor, initiation of empiric therapy targeting MRSA or Pseudomonas aeruginosa. Strongest, if they have this known colonization, okay, and your gram stain shows this, even if they are non-severe and they are admitted in the hospital, then the recommendation is start them immediately on Pseudomonas and MRSA. If, on the other hand, they carry weak risk stratification, get your isolation, but start or initiate Pseudomonas and MRSA only if you're able to identify organisms on your microbiological studies. So there's a distinction between a severe patient and the non-severe patient in the risk factor that they carry, and what is recommended to start them with immediately. So here is the American recommendation, severity and risk stratification. Non-severe individuals are started with this combination drug to cover for most core organisms, Streptococcus, H. influenzae, a typical organism. The main difference from the American recommendation is the use of respiratory fluoroquinolone. In the Philippine setting, we do not recommend the use of respiratory quinolone as a solo agent for non-severe individuals who are admitted in the hospital, essentially because these respiratory quinolones have very good activity against drug-resistant tuberculosis, and we would want to preserve these these agents, these antimicrobial agents, for the treatment of MDR-TB in the Philippine setting, because there are other choice anyway, and therefore this is one departure of the recommendation from our local guideline, not to use respiratory quinolone as a solo agent for individuals who are admitted in the hospital for community-acquired pneumonia, the moderate type. If they have severe infection, then the recommendation of the document is to start them on this regimen, especially if they carry with them risk factor for Pseudomonas, because these are anti-pseudomonal drugs, and if they also have carry with them risk factor for MRSA, like prior isolation and drug use, IB antibiotic use in the previous years, in the previous 90 days, then anti-MRSA drugs like vancomycin, but preferably they recommend linezolid here. But they escalate immediately from using the anti-MRSA drug if not isolated from respiratory or blood culture and the patient is improving at 48 hours. Their recommendation is take it out, either vancomycin or linezolid. But this document favors linezolid because of its inhibition of bacterial exotoxin and better lung penetration as far as MRSA is concerned. So this is the American guideline. So these are some of the common antibiotics that you have reviewed in your second year in pharmacology: beta-lactam, macrolide, tetracycline, fluoroquinolone, aminoglycoside, and glycopeptides. And there's a new group of drugs. This is super antibiotics to address the super MDRO drugs. These are combination drugs: avibactam, ceftazidime, and targeting specifically organisms with specific drug-resistant patterns. Now, complication of community-acquired pneumonia would be metastatic infection. Although they say it's unusual for Streptococcus pneumonia, you can have disseminated Streptococcus pneumonia infection coming from your pulmonary infection. From initially localized in the lungs, it can go into hematogenous spread, and you have CNS infection, meningitis, you have bone problem, you have joint problems. And you can have brain abscesses coming from just simple Streptococcus pneumonia. And then we will discuss later on lung abscess, those with necrotizing infection. Even if I say that Pseudomonas aeruginosa and MRSA are the typical cause of lung abscess or lung or necrotizing pneumonia, even Streptococcus pneumonia can do that. Complicated parapneumonic effusion, and that's the reason you watch out if there is concomitant pleural effusion in a patient with pneumonia, because if they are complicated, then you need to aspirate, and send it for examination, because some of these individuals may not respond to antibiotic alone and may require insertion of pleural drain to adequately control the infection and prevent pleural sepsis. So this is the local guideline that we have, low risk cap without comorbidities, and those with comorbidities, the recommendations are so. If they are moderate risk cap without risk, then these are the recommendation. But if they are high risk cap without MDRO risk, these are the recommended antimicrobial treatment. With MDRO risk like Pseudomonas, then anti-Pseudomonal drugs are added. And if there are risks for example, ESBL or even MRSA, then those additional antibiotics are going to be placed in the context of the clinical picture. ESBL risk, on the other hand, is prior isolation of an ESBL organism in the past year and use of second and third generation cephalosporin, because these are the drivers for ESBL production. And subsequently, you might have to use carbapenems instead of your beta-lactam drugs. So just in highlights, these are without comorbidity, outpatient treatment, amoxicillin 1 gram 3 times a day, or azithromycin or clarithromycin. But if they have stable comorbids, controlled comorbidities, then a combination of drug, amoxicillin, clavulanic acid, BLI, cefuroxime plus or minus macrolide. When do you add? You add if they have additional symptoms like non-pulmonary symptoms as like gastric upset, because those are indicators of sometimes atypical or the presence of atypical organism. And therefore, BLI are 2 drugs plus your atypical coverage, just make it 3 drugs. So in general, you have 2 pills to take, the beta-lactam drug or second-gen cephalosporin plus or minus your macrolide. On the other hand, non-severe who are admitted in the hospital setting without MDRO risk, like risk for Pseudomonas, are treated with this combination drugs plus macrolide. And following an unsatisfactory response, you need to review why. Is the diagnosis proper, or are you dealing with an organism that is resistant to the antibiotic that you have used, or are there complications? So a follow-up X-ray may be done. If there's a development of pleural effusion, then you need to address that particular complication of the treatment. Now, these are individuals, again, admitted in the hospital setting. The recommendation also carries with it that if empiric antiviral treatment during the peak seasons of influenza, optional to give during periods of high influenza activity, and especially if the clinical picture is preceded by an influenza-like symptoms, or if you have identified, because we have influenza swab, RT-PCR based swabs to tell you whether you are dealing with influenza A or B, or even some of the other types of influenza, because you have specific antiviral treatment, oseltamivir is locally available if you have identified influenza A or B. The alternative treatment here is non-pseudomodal beta-lactam drug plus. And again, remember that in the US, they would recommend monotherapy. Here, it is in combination with a non-pseudomonal beta-lactam antibiotic, levofloxacin and moxifloxacin. Now, risk factor, MRSA, non-pseudomonal, if they don't have pseudomonal risk, plus macrolide or respiratory quinolone. And here, locally, different from the American recommendation of vancomycin and linezolid, we're still recommending the use of clindamycin because the studies, microbiological studies, the surveillance of resistance and susceptibility pattern tells us that they might still initially be responsive to clindamycin, and therefore clindamycin is still part of the recommendation if we're thinking MRSA. If, on the other hand, you have pseudomonal risk or ESBL risk, non-pseudomonal beta-lactam, the antibiotic ertapenem. Meropenem has anti-pseudomonal activity, but ertapenem may not be readily available. So meropenem may be used in substitution, although it's more expensive, plus a macrolide or respiratory fluoroquinolone. Risk for Pseudomonas aeruginosa, replace the non-pseudomonal beta-lactam with any of these anti-pseudomonal drug. Okay. Plus a macrolide or respiratory quinolone, but the American recommendation, if you have a severe illness, they would prefer a macrolide versus a respiratory fluoroquinolone because of better clinical outcome. So in a local guideline, a typical coverage for aspiration pneumonia should not be routine because some of the medications that you're using, for example, sulfatamicillin has anaerobic activity and moxifloxacin as well. So if those two drugs are part of your initial regimen, you don't need to cover anymore with clindamycin for anaerobic coverage, except when lung abscess or empyema is suspected or developed. So again, this is microaspiration, not macroaspiration. Somebody who vomited and aspirated, that's macroaspiration. But this is microaspiration that we're talking about. There are some consideration because both macrolides and respiratory fluoroquinolone has concern related to arrhythmia, arrhythmogenicity, and therefore if they have QT interval problem, a prolongation, both of these can prolong QT and therefore can set them up for dangerous tachyarrhythmias. Quinolone, on the other hand, may also have connective tissue problem, including rupture of Achilles tendon. So these are considerations that you need to consider or keep in mind when you are going to use these particular drugs. However, if the atypical organism is really a consideration, your patient has diarrhea as well, together with respiratory problem, then doxycycline, a tetracycline drug, may be used because they have atypical coverage, but not as good as these two other drugs. But they are may be used as a substitute for coverage for a typical organism. Now, antiviral treatment, as we said, if this happens during the high season of influenza during July to January and February, the colder months, then an additional antiviral medication may be considered if they are 60 and above, pregnant asthmatic or unstable comorbidities, and who tested positive for influenza virus. Now, this is a recent recommendation from 2025 IDSA, Community-Acquired Pneumonia, that individuals with severe cough, they suggest it's a different when they say recommend. Recommend means routinely use it. They suggest systemic corticosteroids because of the benefit that they have seen in individuals with severe pneumonia. However, this should exclude individuals with severe pneumonia because of influenza, identified influenza infection, because the studies do not yet show any benefit with influenza. Not that it becomes detrimental to them, but there is no significant information yet to support its use in individuals with severe influenza pneumonia. For your usual bacterial infection with severe community-acquired pneumonia, ATS now is recommending or suggesting the use of systemic corticosteroids. Again, some of the important recommendations: outpatient without comorbidities, who have clinical and imaging evidence of CAP but test positive for respiratory virus, treat the respiratory virus and do not use or add antibacterial agents, because these are individuals who are relatively young and relatively healthy. But patients with comorbidities, they suggest to cover with bacterial infection because of the high incidence of bacterial viral co-infection, as high as 30% in some series. And therefore, if you have elderly with comorbidity, you have identified viral infection, the recommendation is also cover for the usual bacterial coverage for community-acquired pneumonia. Okay. How soon should you start? In the earlier document, within an hour of identifying that your patient has especially severe type of bacterial pneumonia, get your cultures immediately and start your antibiotics. Because as soon as you start, the better the outcome, the chances of dying from it is also lesser. Duration of treatment: for most individuals who are stable within 48 hours, able to eat, stable vital signs, and those who are confused immediately regains their level of sensorium, the recommendation is just 5 days. Extension, on the other hand, may be considered in patients whose pneumonia is resolving slowly. If they are complicated with this condition, sepsis, meningitis, deep-seated infection, infection with less common pathogen like myelioidosis, M. tuberculosis, and endemic fungi, for example, infection with the drug-resistant pathogen, you cannot give them just 5 days. If they have Pseudomonas or MRSA or ESBL, then the treatment may be prolonged rather than just 5 days. De-escalation or stepping down your antimicrobial treatment once they're clinically improved, hemodynamic stability, your culture came out, and you can de-escalate or bring it down to less broad spectrum antimicrobial, and this is targeted culture guided targeted treatment. PO tolerability, and the recommendation is, if you're going to switch, use the same agent and same drug class. Don't shift to from one to another, because you have already had an assurance that the clinical response is adequate. Monitoring response to the X-ray: individuals who are responding should not or is not recommended to have an X-ray. However, for elderly individuals with risk factors, or you want to establish a new baseline, get the repeat study 4 to 8 weeks or 6 to 8 weeks after, because that is how delayed the radiographic resolution of the usual bacterial pneumonia. Even longer, the resolution may even be longer in individuals with comorbidities and elderly. If you have COPD, bronchiectasis, in an elderly individual, the resolution of these types of pneumonia even takes longer than 8 weeks, and you need to monitor them more closely. So the response is expected. Follow-up cultures in an improving individuals are not necessary. However, additional studies in non-resolving or non-responding in patients may be indicated, including invasive transtracheal transthoracic aspiration, or even biopsy, bronchoalveolar lavage, protected brush specimen, to obtain the specimen to reinvestigate on why you are failing, especially concerning multi-drug resistant organism. So streamlining or de-escalation are all of these things. Switch. These are the common agents from amoxicillin clavulanic acid, and these are the dosage. You need to provide them with adequate dosage for the resolution, adequate resolution of your process. These are the things that you need to tell your patient, that even if with successful treatment, the resolution of some of the symptoms and signs may take a while. 1 week, fever should have resolved and should not be persisting. 4 weeks, chest pain and sputum production should have substantially reduced. 6 weeks, cough and breathlessness should have substantially reduced. At 3 months, most symptoms should have resolved, but fatigue may still be present, especially in the elderly and with comorbidities. And at 6 months, most people will feel back to normal, but in younger individuals, this may not take 6 months. But individuals with pre-existing COPD, bronchial asthma severe, renal failure, congestive heart failure, it may take months for them to go back into their premorbid status. Measures to prevent community-acquired pneumonia. First is smoking, the number one risk factor why they are become susceptible to lower respiratory tract infection. And then we have effective vaccines against pneumococcal infection, and routinely seasonal influenza vaccination is going to be given. For adults 50 and above, part of the recommendation is give them flu vaccine, pneumococcal vaccine, conjugate vaccine, give them shingles vaccine, renew their Tdap, tetanus, diphtheria, and pertussis vaccination. Also, vaccination against RSV for 75 and above, but 60 with comorbidities. RSV is becoming recognized as a significant contributor to morbidities, including especially cardiovascular morbidities in individuals who develop this type of infection. They present mainly like flu-like symptoms, body aches, malaise. They can develop severe pneumonia from RSV. But even if they don't and they develop RSV infection, the complications are commonly cardiovascular in nature. New atrial fibrillation, new congestive heart failure, even when they did not, myocarditis, and acute myocardial infarction. These are some of just the complications that are observed already in influenza infection, but are heightened and higher in RSV infection. And therefore, RSV now is one of those targets for protection in individuals who are at high risk. And then focus on their comorbidities, because these comorbidities are the ones, again, that puts them at a higher risk of developing lower respiratory tract infection. If they have COPD, then their COPD must be controlled. If they have bronchial asthma, control of this bronchial asthma as well. If they are smoking, stop their smoking is top of the list. If they have a congestive heart failure, if they have diabetes poorly uncontrolled, if they have chronic renal failure, their renal failure should be controlled, and their dialysis should be on schedule, because pulmonary congestion can set them up for infection. So again, these are the recommendation. Healthy 50 years and above should have regular influenza vaccination and pneumococcal vaccination as well. And this is the recommendation adopted from ACIP for the adult vaccination. And you may want to look at this for your parents or your grandparents. Now, moving on, just to segue into the lower respiratory tract infection happening in the hospital setting. Hospital-acquired pneumonia and ventilator-acquired pneumonia are leading causes of ICU-acquired infection. The second leading cause of nosocomial infection, increased mortality and morbidity, despite improvement in antibiotic treatment and supportive care, and it is associated with increased healthcare costs. Gram-negative bacilli remain the most common bacterial causes of HAP and VAP in about 50 to 80%, and multi-drug-resistant organisms at diagnosis is strongly associated with initiating inappropriate antibiotic from the beginning, and the outcomes are going to be bad if inappropriate antibiotic is a concern. So these are the new definitions related to this hospital-acquired infection. Pneumonia that occurs 48 hours or more after admission, but was not incubating at the time of admission. So if they get admitted with a pneumonia, then that's community-acquired pneumonia. If they acquired it 48 hours and above or longer in the hospital setting, that is HAP. An individual who developed HAP and eventually needs to be ventilated because of the severity of illness is now called ventilated hospital-acquired pneumonia. Ventilator-associated pneumonia is an individual who gets ventilated for other reasons, but eventually develop evidences of pneumonia 48 hours after mechanical ventilation. As I said, this is not the mechanical ventilator at fault, but rather the intubation that is required to match or couple your patient to your mechanical ventilator. And this is the new concept that we have now, that in the hospital setting, you have all of this risk factor. Poor chest physiotherapy, poor oral intake, oropharyngeal colonization, as I said, within 24 hours of admission into the hospital, whether ICU or non-ICU, you get colonized. Then sometimes they will receive sedation for agitation or inability to sleep. They might be delirious from any of the indications why they got admitted in the first place. And so you have all of these contributing to accumulation of purulent mucus secretion in the lower respiratory tree. And they develop hospital-acquired infection in the ward. If the initial treatment of that hospital-acquired pneumonia is failing, and then subsequently they develop respiratory failure, then they become intubated and they now become ventilated hospital-acquired infection. On the other hand, if they immediately get admitted into the ICU for varied reason, acute MI, congestive heart failure, they may develop pneumonia in the ICU, and they are called non-ventilated ICU-acquired pneumonia. However, again, if they get intubated, then they develop ventilator-associated pneumonia. Patients with ventilated HAP are at risk of even higher mortality rates than patients initially with ventilator-associated pneumonia, because there are bundles that prevent the possibility of acquiring pneumonia after being intubated and mechanically ventilated. But an individual who developed severe hospital-acquired pneumonia had already gone into the process of respiratory failure before becoming intubated and mechanically ventilated. And the mortality rates are much higher. You see, HAP has about 22% mortality rate. Mortality rate from individuals who gets ventilated after developing hospital-acquired pneumonia is almost 40%, while for ventilator-associated pneumonia, the mortality rate is about 27%. So an individual who deteriorates from HAP to being ventilated and mechanically ventilated, the outcome is much poorer. This is an earlier study, a 2016 guideline for hospital-acquired and ventilator-associated pneumonia. This is from the United States. There, immediately after one year in 2017, the ERS, European Respiratory Society, and ESMID, this is the European Society of Microbiological Organization, also formulated their own recommendations. And this is previously HCAP was still included here, but this is the flow of diagnostics and subsequently the steps that you need that is recommended for immediately starting them on antibiotics, and the way to move forward from management of this individual. And again, the message is commonly prompt empiric antibiotic for patients with hospital-acquired pneumonia, looking at the risks that they bring with them. Is there a risk for aspiration? Have they been exposed to antibiotic? Are they potential Pseudomonas MRSA or ESBL harboring organisms? Because the empiric treatment that you will recommend is immediately administered, because a delay increases mortality. A delay, for example, a patient with sepsis, if you delay by 1 hour your antibiotic administration, the mortality rate increases every hour by 11%. So these are the risk factors and factors affecting initial treatment. These are the multi-drug resistant risk factor for BAP, prior antibiotic use, septic shock at time of BAP, ARDS preceding BAP, 5 or more days of hospitalization. This is the distinction between early and late ventilator-associated pneumonia, because early, before 5 days, they commonly are harboring community-acquired pneumonia organisms, and therefore they are treated as CAP. Acute renal replacement, risk factor for MDR, prior antibiotic use. Factor for MRSA, again, antibiotic use in last 90 days. Pseudomonas, so you can see the prior broad spectrum antibiotic use in the last 3 months. These are uncommon causes, etiologic agents for ventilator-associated pneumonia, Legionella, anaerobes, fungi, viruses, and Pneumocystis jirovecii. Anaerobes, except when they are during ventilation, that the patient inadvertently aspirated as well, then you consider the possibility of anaerobes there. So again, the message for an earlier onset of HAP or BAP, they are commonly colonized with organism out in the community, and therefore the antibiotic that is used is similar to a severe community-acquired pneumonia. Late onset, on the other hand, increases the risk of multi-drug resistant organism causing the problem, and risk factor for hospital-acquired pneumonia that have been detected over the years. This is in the wards, a depressed level of consciousness, enteral nutrition, malnutrition, mechanical ventilation. This is no longer HAP, but rather ventilator-associated pneumonia. Oropharyngeal colonization, which is universal among individuals who get admitted. Intubation and extubation, early extubation or accidental extubation and reintubation. Use of stressful prophylaxis that changes the pH of the gut because they now become colonized with gram-negative organism. If they are remaining flat in supine position, and therefore part of the prevention here is put them at 30 degrees elevation, and then never allow them to lie flat on bed, especially if they are on tube feedings. If they are elderly, if they are immunosuppressed, if they are coming from thoracic or abdominal surgery, and if they have multiple chronic lung chronic clinical condition, chronic congestive heart failure, chronic lung disease, chronic heart disease. So ventilator-associated pneumonia do not depend on, this is, I have not corrected this, but ventilator-associated pneumonia, unlike hospital-acquired pneumonia, where the patient may spontaneously expectorate sputum, or you can induce sputum, then you can isolate the organism. But BAP, on the other hand, because they are already intubated, the common organism is obtained by aspiration from the endotracheal tube. And 3 factors for the development of ventilator-associated pneumonia is 1, colonization of oropharynx with pathogenic microorganisms, aspiration of these to the lower respiratory tract, even if they are on endotracheal tube, a secretion can pass through on the sides of the endotracheal tube and subsequently lands itself into the lower respiratory into the lung parenchyma, in the compromise of the normal host defense mechanism of these individuals. And then you can see that multiplicity of these problems, which are not present in a normal individual. You intubate, then you bypass the normal protective mechanism of the upper airways, and subsequently they're set up for the infection. So microaspiration by pulling of secretion above your cough. If you have seen an endotracheal tube, there's a cough there that's supposed to prevent aspiration of secretions from the upper respiratory tree, but this does not 100% protect them from aspiration. Suctioning, on the other hand, through the endotracheal tube can damage the trachea mucosa and cause colonization and introduction of the organism into the mucosa itself. And the pathogenic bacteria now, the colonies of the organism can now develop inside that endotracheal tube, and they can now have a biofilm in the colonizers, and these subsequently get introduced every time the patient is suctioned, and this organism can be reintroduced in the lower respiratory tree. And this is what happens in the hospital setting. Those are the sources. You have endogenous from the patient himself, whether they are receiving NGT feeding or not, then these are the sources of your problems. They can aspirate, causing hospital-acquired pneumonia, and even bacteremia because of this invasiveness of these processes. Exogenous, on the other hand, healthcare workers may not be careful enough in washing their hands and transmitting one infection from one patient to another. ventilator circuits contamination, the nebulizers, biofilms that I've already talked about that can form inside your endotracheal tube. Then these are pushed now into your individuals who are intubated and mechanically ventilated. And this is the process wherein hospitalized patients or ventilated patients may get this particular problem. You can just look at this picture of these individuals with dialysis machine, an endotracheal tube with mechanical ventilator, and some of these all gadgets and those IV lines, access lines, Foley catheter, a chest tube. If they have draining chest tube, they may have surgical drainage tubes as well. So these are the risk factors: colonization with pathogenic organism. Risk factors from the host, they need to be on a supine position because of reasons like extensive burns or fractures, need for mechanical ventilation, cardiothoracic surgery. They develop ARDS if they have had trauma. Then you have the whole environment in the critical care unit with nasogastric tubes, ventilator tubing. And then you have some of the interventions that needs to be done, like acid suppression for prevention of stress, bleeding, or ulceration from severely injured individuals like stroke patient or traumatic injured patients. And again, these are some of the host factors that have been identified that sets them up for the development of ventilator-associated pneumonia. So non-MDR pathogen for VAP, intubated patients coming from the community again, and non-MDR pathogen. And then you have an antibiotic sensitive Enterobacterales, E. coli, Klebsiella, Proteus, Enterobacter species, and Serratia. So your antibiotic coverage for these individuals would be just like a severe community-acquired pneumonia without medical or MDRO risk. MDR pathogen, on the other hand, are Pseudomonas, MRSA, Acinetobacter, ESBL, carbapenem-resistant organism, Legionella, Burkholderia cephacea, and fungal infection. So, clinical manifestation, low respiratory tract signs and symptoms, new progressive infiltration X-ray, leukocytosis, or depleted WBC, worsening blood oxygenation, and increasing requirement for oxygen to improve or maintain a current status of saturation. The differential diagnoses are numerous: pulmonary thromboembolism, pulmonary edema, pulmonary hemorrhage, drug reaction, and even tracheobronchitis can give you this particular increase in symptoms and purulence of secretion. But if you don't see any new infiltration on the lungs, then you might be dealing with tracheobronchitis. Sinusitis, because of the presence of a tube in the tracheal tube or nasogastric tube, can cause the syndrome of increasing fever, increasing leukocytosis, but no infiltration on the X-ray. So these are part of the differential diagnosis. New progressive or radiographic infiltrate, at least two of the following: and leukocytosis, purulent secretions, in hospitalized patients with on mechanical ventilator. Clinical criteria often results in overdiagnosis of pneumonia. And therefore, some of the problems then is how to get the appropriately samples, and some of the recommendations elsewhere is to use bronchoscopic lavage using protective specimen brushing to diagnose ventilator-associated pneumonia. And this type of setting avoids the contamination of the lower respiratory tree by using special tubes and special machines, none of which are readily available locally, and therefore the recommendation generally is use endotracheal tube aspiration for identification of our organism, because these are the criterion that are used for bronchoalveolar lavage with the protected specimen brushing. And you see quantitative ETA, protective specimen brush, and bronchoalveolar lavage. These are quantitative and not very many laboratory even in the States, and none in the even in Metro Manila are able to do this quantitative testing. So you lack the proper facility for bronchial alveolar lavage, and you lack the microbiological support to establish this criteria for a colonizer in actual infection. And therefore, the recommendation from the latest 2016 guideline is to use non-invasive sampling. Even now, this has not been superseded yet because of the recognition that the facility for invasive sampling are hard to come by, and the microbiological laboratory support are also much more difficult to come by. So we are relying on ETA aspirate to identifying microorganisms. And some of the principles, you need to consider duration of mechanical ventilator 7 days or more, prior antibiotic use, prior use of broad spectrum drugs, and starting them on broader still antimicrobial now may be helped by using your PCR-based laboratory parameters, which I will briefly touch on. You can get the sample, especially and hopefully sterile sample. You can get aspirates. If you have pleural effusion, you can have transthoracic aspiration of secretion from the lungs that you can send now for RT-PCR based determination of organism that may be able to help you to circumnavigate some of these, or circumvent rather, these problems related to isolation of pure sterile samples to identify your organism. So from Harrison's, this is the recommendation for coverage of ventilator-associated pneumonia. No risk factors. You use anti-pseudomonal drug, cepipims, levofloxacin. Risk factor for drug-resistant gram-negative pathogen. Again, use any of this drug plus some of the combination. Sometimes you may have to use the combination. And if there's a risk factor for MRSA, add linezolid or adjusted dose of vancomycin, because vancomycin is nephrotoxic and needs regular adjustment and regular monitoring of the kidney function to be able to reach recommended trough levels and to prevent nephrotoxicity. Prevention for hospital-acquired pneumonia and ventilator-associated pneumonia, alcohol-based and soap-based hand disinfection, surveillance, avoiding or minimizing the duration of endotracheal intubation, or preventing intubation at all, and therefore the use of non-invasive mechanical ventilator in appropriate clinical setting is recommended to avoid this translaryngeal airway insertion that prevent or sets them up for ventilator-associated pneumonia. Minimizing the risk of microaspiration by putting your patient on eye sitting. Preferential use of enteral nutrition rather than parenteral nutrition, and use of restricted transfusion trigger policy for blood products, because blood product transfusion is one of those risk factors for the development of problems. So these are some of the risk factors and the recommended strategy to prevent all of these risk factors for the development of hospital-acquired pneumonia and ventilator-associated pneumonia. So duration of therapy, if you are not able to identify MDROs, then the treatment should be 7 to 8 days. The meta-analysis shows that the 7 to 8 days is no different from longer in terms of mortality, treatment failure, recurrent pneumonia, and duration of mechanical ventilation. Okay. Certain pathogen, on the other hand, like non-lactose fermenting gram-negative organism, especially Pseudomonas aeruginosa and some of the Acinetobacter species, should be treated longer duration due to risk of the recurrence. Exceptional situations when the diagnosis is delayed and inappropriate antibiotic was a problem, and eventually you have identified multi-drug resistant organism after you have started the medication. So I've mentioned some of the new developments in rapid diagnosis and using syndromes like community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia, because this PCR-based testing allows you to identify organisms, especially coming from blood cultures, respiratory infection, infectious diarrhea, or even CSF evaluation of this testing, that you can have results within 1 hour and a half uh, of submission of the samples, and subsequently it can immediately guide you. But be sure that you are guided by what kind of specimen you're submitting. If it's blood and you're able to identify the organism, then it's likely the causative agent. The same goes for CSF. The same goes for aspiration samples from pleural effusion, for example, because these are normal, sterile, and uncontaminated ones. But if you submit an ETA aspirator, expectorated sputum, then these are uh, subject to a lot of contamination, and you need to consider that possibility. So these new panels can help the diagnosis, but still needs microbiological confirmation. So although this can help clinicians to a rapid diagnosis and evaluation and initiating of treatment, these are not readily available. It's quite expensive, and it must be tempered with clinical judgment and microbiological identification of organism. So these are all the caveats that you have to or caution related to the use of this new RT-PCR based. Now, we mentioned earlier that the complication of lower respiratory tract infection is lung abscess, and we were going to do that. Now, this is the left apical segment, and you see air fluid level in a large cavity, and this is a destroyed lung with fluid inside because you now have an air fluid interface. And this is one of the complications of your lower respiratory tract infection, resulting from a necrotizing process and cavitation of the lung following parenchyma following a microbial infection. So it can happen in community-acquired pneumonia, it can happen in HAP, and it can happen in ventilator-associated pneumonia. It may be single or multiple, but usually are marked by a single dominant cavity more than 2 centimeters in diameter, and it subdivided into a primary. 80% of cases of lung abscess are primary, arise from aspiration, often caused principally by anaerobic bacteria. And we said microaspiration, anaerobes is not a concern, but macroaspiration is. Alcoholic who vomited and aspirated his vomit, neurological patient who again cannot protect his airways and witness macro aspiration. And it may occur in the absence of underlying pulmonary or systemic condition, except for the fact that they have macro aspirated. Secondary lung abscess, on the other hand, arise in the setting of an underlying condition such as post-obstructive process or a systemic process. For example, if you have lung cancer and that lung tumor is obstructing an airway and cannot drain a lobe properly, and eventually that lobe becomes infected and the secretion cannot be drained, then that becomes a secondary kind of lung abscess. It may present acutely, less than 4 to 6 weeks of duration. In individuals longer than this may be chronic, and this is 40% of the cases. And even the acute phase is quite a subacute in nature, because the event, aspiration event, may occur weeks earlier on, and they are now just presenting to you 4 weeks or 6 weeks after that event, and that may still be considered an acute process compared to the acuteness of community-acquired pneumonia that occurs in days. So the major risk factor for primary lung abscess is aspiration, and as I said, this is macro aspiration. Especially in an individual who has poor dental care with colonization of dental crevices by anaerobic bacteria or microaerophilic streptococci, periodontal disease, and the risk of aspiration. Again, the alcoholic, the stroke patient, the stroke victim with swallowing problems, with the inability to protect their airways. So anaerobic bacteria from the mouth eventually gains access into the lower respiratory tract and then into the lung parenchyma, developing an inflammation in the lung parenchyma. And especially if they're aspirating gastric content, the gastric acid now also partly dissolve your lung parenchyma and results into the necrosis and cavitation. And then if the immune response of these individuals is impaired, that they are elderly, they have significant multiple comorbidities, then the progression in the development of lung abscess. Secondary lung abscess, on the other hand, is, as I mentioned, from a malignancy or a foreign body that has been aspirated and unrecognized. It prevents clearance of oropharyngeal secretion, leading to abscess development. If they are immunosuppressed, host defense is impaired, increased susceptibility to development of lung abscesses, and even from opportunistic organisms like fungal infection. The dependent portion in primary abscesses, the posterior upper lobes and superior lower lobes are the most common location because these are the direct connection of your airway, and therefore aspirated secretions or materials are deposited in here one. And generally, the right lung is affected more commonly because of the direct extension of the right mainstem bronchus from your trachea, because the lung, the left main bronchus takes off as at an angle from your trachea, and therefore most of the aspirate goes into the right mainstem bronchus. And then in the secondary lung abscesses, the location of abscess may vary according to the underlying cause or where the obstruction might be. In the primary lung abscess, it's open polymicrobial, primarily including anaerobic organisms, as well as some of these organisms that are anaerobic in nature. They are obligate anaerobes. Secondary lung abscesses are more associated with broad bacterial spectrum with infection by high-risk organisms like Pseudomonas and other gram-negative rods like Klebsiella, E. coli. So lung abscesses clinical considerations, the organisms are here enumerated. Risk factor for aspiration, secondary lung abscess with underlying immunocompromise. Again, broader organisms are entertained. Embolic lesions, for example, if you have bacterial endocarditis, or thrombus elsewhere that becomes infected and is thrown now into the lungs, then you have all of these organisms that may cause your lung abscesses. Endemic infections with or without underlying immunocompromise. Tuberculosis is our national disease, and therefore it can result into lung abscess. Those cavitary images of lung tuberculosis or pulmonary tuberculosis are considered lung abscesses. Miscellaneous conditions like bacterial pathogen from S. aureus, especially in a setting coming from an influenza-like illness, because influenza sets us up for staphylococcus infection. So again, commonly mixed infection for microaspiration, and therefore antibiotics are directed towards this. There are certain situations where you might have to consider parasites like Paragonimus and Amoeba and Echinococcus, including in the Southeast Asian countries, including in the Philippines, especially where such parasitic infections are endemic. Secondary lung abscesses may develop from congenital lung abnormalities, malignant tumors, foreign bodies, and bronchiectasis. It may also complicate pulmonary infarction in pulmonary embolism. It's not a common occurrence in pulmonary embolism, but individuals with pulmonary infarction can develop lung abscesses from those infarcts. Primary lung cancer, metastatic malignancies, and some of these clinical conditions that set them up for obstruction in the airways, destruction in the lung parenchyma, though they are bland, may eventually be colonized and subsequently develop infection. The presentation is similar with pneumonia, cough, sputum production, and chest pain. The more chronic and indolent presentation includes night sweat, fatigue, anemia with anaerobic lung abscesses, but you are familiar with tuberculosis that they present with more than 2 weeks of cough, fever, night chills, weight loss, loss of appetite. A subset of patients will presents with foul-smelling sputum, and this may be accompanied with with greenish, yellowish, and mixed with blood, foul-smelling and foul-tasting sputum. Maybe a dead giveaway for an individual with lung abscess. Fulminant course for methicillin resistant organism. And then you have your correlates with physical examination, cavernous breath sounds if you have a large abscess, and you might be able to identify this. X-ray, usually thick walled cavity with air fluid level that we have seen earlier on the X-ray. CT scan permits better definition. Additional diagnostic testing like bronchoscopy to rule out mass lesion or foreign body. CT-guided percutaneous biopsy may also be needed. And the diagnostic testing may pose their own risk. But if you need to identify the organism, then some of these things may have to be done. And this is the earlier example that we had. You had a large cavity here with air fluid level denoting secretion and fluid in an air that is interacting with your fluid, and therefore the air fluid level that is the usual presentation of abscess. And here, let's say the CT scan correlates now of your patients with abscess. You have this filled up region of the lungs, and then you have this cavitating lesion here that may be aspirated. Okay, see, these are some of the regimen, the antibiotic regimen. If the abscess is large, then surgical drainage may be done, and these are some of the antibiotics that may be administered. Secondary lung abscesses approach, again, the recommendation is going to be whether they have multi-drug resistant organism risk factors. The regimen may be protracted, antibiotic utilization. So large abscesses more than 6 to 8 centimeters are less likely to respond to antibiotic alone, and therefore surgical or percutaneous drainage may be an important adjunct to this medication. This is one example of a CT-guided directed insertion, transthoracic sampling of pulmonary abscess just to get samples from here. And a catheter, indwelling catheter, may be sometime left in place here to drain this particular lesion. So large cavity size, development of persistent cystic changes. You here now see a lower portion. Antibiotic treatment was given. Several weeks, a thin-walled now still remains, and this thin-walled cavity may still be colonized and filled up again with another episode of lung abscess. Recurrence may be common. Extension to pleural space may also be there. They can develop life-threatening hemoptysis and massive aspiration of lung abscesses content. This content during positioning, lying down, sleeping, can go up into the upper airway and be aspirated into the contralateral lung. And therefore, this is quite a significant recurrent problem and carries with them a big morbidity and sometimes rapid morbidity or mortality if they go into massive hemoptysis. Primary lung abscesses, low mortality rate as 2%. High prevalence, on the other hand, as high as 75% mortality rate in some case series. Poor prognosticators if you have an elderly individual, presence of aerobic bacteria, sepsis at presentation, more than 6 weeks on presentation, and abscess of more than 6 centimeters. So the approach is all of these mitigating factors, prophylactic treatment, look for risk factor, especially HIV. And that ends our presentation, quite a long presentation. These are some of the references. Some have been updated, the 22nd Harrison's edition. You have the 2025 IDSAATS report. You have the 2020 Philippine guideline. The guidelines for HAP and BAP are quite old and maybe up for revision, but so far these recommendations still stand at the moment. So there are some perhaps minutes for us for your questions, but I would have also encourage you to have made your questions and put them on the chat box and that we can address that. Should you have questions that are not addressed in this session, then forward them to the secretary and I will try as much as possible to get to you with the appropriate answer to your queries. And with that, thank you very much for staying and hopefully this helps you in the recognizing that the common presentations of pneumonia, risk factors for MDROs and how to address them with antibiotics. Then we went to hospital-acquired and ventilator-associated pneumonia, and then subsequently address the problem with lung abscess. Again, thank you very much, and have a good day, everyone. Yeah, thank you for the hearts, but I haven't seen any question from your from the chat box. But I also noticed that most or more than half just logged in after 4 o'clock, and so there might have been miscommunication about the start of the lecture. But this recording will be uploaded in Vimeo, so you for those who had missed it, you can review the portion that you have missed, and hopefully again that this is quite helpful in your approach to the diagnosis of this very common clinical problem. You will see this, you definitely will see this in your practice, whether you're practicing as a generalist or a specialist. And the guidelines are evolving, and every so often you need to check whether there is an updated one. Again, driven by the revisions are driven by new understanding and new diagnostic testing. For example, this multiplex PCR-based diagnostic testing are gaining popularity for immediate diagnosis and even diagnosis of drug-resistant mechanisms, and therefore the choices of antibiotics that are quite expensive will have their role, but this role are not for your common type of community-acquired pneumonia, but rather for those with multi-drug resistant organism, and especially for immunocompromised patients where immediate diagnosis is important and the right antibiotic that should be started soon enough may make a difference whether they die or survive this episode of infection. So again, there are still no questions that are posted here. Thank you very much. I'm not sure if you have another session that comes after this, but have a good day, everyone, and good luck in your examination. And again, the examination is going to be guided by what you have heard, what we have discussed, and what is, I want you to go back and read Harrison. It's quite an easy reading, especially if you use some of the principles that we have discussed today. Thank you and have a good day, everyone.
Thank you, Doc.
Thank you po, Doc.
Thank you po, Doc.
Recording stopped.